we get patients under our care with Harry Hines Hospice way too late in that progression of their disease process, because it always seems there's always something more you can do as far as curative interventions. I remember early on, so I was visiting with an oncologist in the early 80s about, he had a great resistance to bring his patients under the care of our program. And so I called him up and he invited me, yeah, come on down, love to visit with you over lunch. He said, I'll treat you to lunch, bring it in the office here. So as we were moving along, I simply challenged him, doesn't there come a point when you have to tell one of your cancer patients there's nothing more you can do? And he knew what I was asking in terms of the curative, that it would be futile. And you can guess what his answer was. He's a very good clinician, a very good oncologist. His answer was very simple and to the point, word for word. When it comes to treating a cancer patient, there's always something more you can do. Well, he's right in terms of the protocols, the interventions, but what about the ethical part, the benefit burden, the beneficence part? Sooner or later, you're going to have to say, this is not going to be beneficial for you. As a matter of fact, it'll probably really make it more difficult for you to live your life well. Truth be known, just weave that in real quickly. I've known this anecdotally for a long time, that if a patient's not going to, especially in cancer, not going to benefit from the curative treatment, and you continue with the very aggressive stuff with all its bad side effects, it can actually shorten life. Patients who have foregone it, not only is going to hospice not a death sentence, it actually may give them more time. And not just more time, but better quality of time. So we need to keep that in mind also. Moving from what I called earlier, the sick to the dying role, the curative to the palliative to the comfort, today is very, very difficult because we have all of those interventions available. But that has to happen. And I also try to instruct physicians on, watch your language, as I said earlier. You're my doctor again, and I've told you over and over, and I'm very grateful for all you've done, tremendous benefit you provided, giving me more time, good time. But I've also made it clear when things really get to the point where you're not going to accomplish what needs to be done by way of cure, I want to know. So I haven't been feeling well, you've taken the tests, I come in, already nervous about what the test may show. Doctor starts off, well, I'm nervous, what did the test show, doc? Well, it shows you've got, cut to the chase here, cancer stage 4. And it's, what, you're a great doctor, you can fix it. And again, you've been told, I want to know. So you hold your own, say, no, you're not going to benefit from this aggressive curative treatment. And then the final way in which I have found over and over again doctors sum it up is, Tom, there is nothing more we can do. And it may again, in the doctor's mind, talk about aggressive curative treatment will be futile. But how do I as a patient hear it? It's this, Tom, I'm done with you. It's abandonment, it's isolation, it's neglect. Good luck, you're on your own. Here I am entering a very difficult, but also a very sacred part of my life's journey, the dying role, in which I still have a lot of living to do, a lot of things to take care of, but I can't do them on my own. What will I need to accomplish that? I need support. And what am I hearing from a very key player? Good luck. Adios, Tom. So I tell them, please, watch your language again. As you make this movement, this transition from the sick to the dying role, entering this important part of my life journey, make it very clear, and I'll use technical language here. Tom, aggressive curative intervention will not do you any good, but we will not abandon you. We will change the focus of our care from aggressive curative to aggressive comfort. You will get the best care possible. Matter of fact, we'll turn you over to a program that will provide you with all the support you need to live life fully to the very last breath in a very dignified way. Very dignified way. And I, in my own mind, might say, this is carrying out the sacredness of life, the sanctity of life. So that's what I really think is so very, very important. If you're looking at what we focus on at end-of-life care, comfort always, people so often equate a normally functioning body with a body that's shutting down, particularly a body with a terminal disease like cancer. And we think if we're out in the garden all day in a hot sun, 100-degree day, and I don't get a drop of water, I'm going to be awfully uncomfortable at the end of the day with thirst. So we think, well, a terminally compromised body also will experience thirst. Not necessarily true. The same way, if I don't get food for an extended period of time, I'm going to be awfully uncomfortable with hunger. When you're looking at a compromised body that is no longer able to function correctly physiologically, for me to force liquids into a body that's not able to handle it is not a comfort measure. So you ask yourself, you take in fluids, medically assisted hydration, whether it's IV or whatever other medical means. If I drink water now, there are 3 ways in which I eliminate liquids. Simplify it a little bit. Obviously, urination. Secondly, perspiration. And the third one most people get stuck on. You blow your breath on a cold mirror, what do you see? Lots of moisture, the condensation there. So you're forcing liquids into a compromised body. The kidneys aren't functioning. There's no activity, so no perspiration, and the lungs are shutting down. What's going to happen to that liquid that you're forcing in? I have literally seen skin break with it trying to get out. So the swelling, the edema, that's not comfortable. And if it settles into the lungs, what happens when you get water into your lungs? We call that drowning. That's not comfortable either. Going to the question of comfort and nutrition now, given medical means, with the medically assisted nutrition means we have. The tubes, if you want to call it that. What happens to food left out in the sun, hot sun? It's going to use the language, rot, decay. So you've got a body that's not digesting food and they're still able to get it in and it's not moving anywhere. It's a warm, moist environment. It's going to be rotting, decaying. That's not comfort either. Matter of fact, patients who are still comprehending and they tell you they're thirsty, you can give them all the IVs you want. It won't satisfy that because you know what they're equating thirst with? Dry lips, dry mouth. That's not alleviated by forcing liquids. That's alleviated with good oral care. Those are the things we've learned and shown very categorically clinically. So if you're looking at a terminal condition, and by the way, a number 58, that's spelled out. You don't want to have medically assisted nutrition hydration from someone obviously in a terminal condition. That's counterproductive. So the bishops are very clear on that. So what we have to learn to do is to provide those measures that really provide for comfort. And the bodies have a natural wisdom knowing how to shut down with the endorphins and all the other things that go on. So we really, when we medicalize dying, we get in the way of the body's natural, wise way of shutting down. How do we provide the best comfort care so that we're really enhancing living until the moment of death, or simply just doing whatever we can to keep a warm body around? So what we really focus on in hospice care is that we want to enhance those things that lead to living fully until the last breath is taken. And that starts with good physical care like we just talked about. So controlling pain, managing troublesome symptoms, that's paramount. You cannot engage in those deeper activities of human functioning, the psychosocial, spiritual, if you've got a body racked in intractable pain. We've got to take care of that. And so our nurses, our physicians, our aides, they're the experts when it comes to that. We get patients on our inpatient unit who are just racked in terrible pain. If we don't get them comfortable in 24 hours, we feel we failed. So we really work very hard at accomplishing that. But if you only take care of my physical needs, pain control, and symptom management, you're just touching the tip of the iceberg when it comes to the total picture of providing me with comfort. You also need to address my functioning in terms of connecting with others, my feelings, my emotional distress, and above all, the purpose of my life, the spiritual. So the psychosocial spiritual can be a greater source of what I call suffering than simply being uncomfortable with pain or troublesome symptoms. So we are very, very careful about doing the maximum in terms of providing for those things that can cause what I call the existential issues, cause a lot of suffering. So we operate very clearly as a team. So the medical people will take care of the physical needs, and then the chaplains, social workers, all of those kind of things that are necessary to take care of the other issues. When I talked about that woman in terms of thank God for cancer, what she was basically saying was, take care of my psychosocial spiritual needs, because those are causing me greater distress than whatever the cancer may bring in terms of my physical uncomfortableness. Truth be known, I think nurses and doctors will get mad at me for saying that, but I think the easiest part to manage in terms of our total functioning as a human being is the physical. I think sometimes the challenges that lie in the existential, the psychosocial, spiritual, they can be of a greater challenge than simply meeting the physical needs. But we definitely have to do that. I said earlier, too, that I tell people, watch your language, that, well, we're just going to let you die up here. No. We're going to do everything we can to support you as you're living here, because every one of us, when we get up in the morning, even though I said earlier the mortality rate for every one of us is 100%, the minute we began our physical existence, we began the dying process. But I hope none of us got up this morning and said, it's a beautiful day, the sun's coming back out after a beautiful rain last night, and the next line we say, but I'm in the dying process. What we really need to tell ourselves, we're in the living process, and we want to make the most out of today. So we're going to do whatever is necessary to enhance life. We're not going to do those things that are going to get in the way, or are we going to do things that will hasten death? So hospice, for example, is very clear about that very point. We don't necessarily prolong the dying, nor do we hasten the death. So that's a fine line in between there. We allow it to occur. Hastening death would mean that we introduce something else that will be on the death certificate as the cause of death. It could be the lethal gunshot wound or whatever else, or the lethal injection that causes the death. That's hastening death. Versus allowing death is that we're not going to put a medical intervention between the event or the condition and death, but we're going to support living whatever time is left as fully as possible. And then on the death certificate, it will be, we didn't put a medical intervention, we allowed death, and that will be the cancer, the heart attack, the Lou Gehrig's disease, whatever you can envision, the stroke. But there are many ways in which you can talk about hastening death, which would be the assisted suicide, where it's illegal in this country, talking about the three-legged stool again, illegal to assist someone, except for about 7 states now, but in Kansas, still illegal. But it isn't that you give me the injection, you give me the necessary drugs, and then I take them. So you assist me in that. In Kansas, that's illegal. It could be also you can give me a gun, we know. Then the person commits suicide. There's legal liability for that, isn't there? So you know those things better than I do as a lawyer. But when it comes to the other part of hastening death, assisted suicide is a bit different than euthanasia. Euthanasia is not that I do whatever to cause my death. Suicide, now it gets to be homicide, where someone else will be responsible for introducing the agent, to use that kind of language, and that introduction causes my death. Now we talk about euthanasia as a good death. That's what the Greek word means. But today we equate it more with what we call the mercy killing, and generally dignified death. Well, I'm not sure I agree necessarily with that. It's interesting to me that the hastening death movement always couches this death with dignity. My point is, why don't we focus on living with dignity till the moment of death? Isn't that more important? And we can do so much to make sure, and when I say living with dignity till death, living life fully to the very last breath. That's what's so important. So that there's a very natural progression from living God's gift of life here and now fully to now transitioning to the gift that we now live most fully in God's presence in heaven. Knowing, loving, and serving God in heaven, giving glory that way. And there's so many categories. I don't know if you want to get into the whole question of euthanasia now in terms of where we are, in terms of possibilities, because in Europe you've got some countries that have all different levels. So voluntary, that's where we would say, I'm the one requesting it. Dr. Sandy, give me the injection, hastening death. Brittany Menard, California, we've got many cases for that happening. So it's voluntary, but we very quickly go to the others, where it now becomes involuntary, meaning I don't want it, but somebody else decides you're not worth keeping around. So we'll do it for your best interest. Even if you don't want it, we'll do it. So that would be involuntary. The non-voluntary would be where you've got infanticide, the child now born with whatever, and so we're going to decide that infant isn't worth keeping around. So that would be the different categories. The other one would be the passive versus the active, which again we have to be very careful about. Let me get into that for a minute. Active, very clearly, I'm introducing the agent, whether it be the bullet or the lethal injection. That would be very clearly causing Tom's death. Passive would be if I'm dependent on the ventilator or whatever medical intervention you want to talk about, I now withdraw that, and that will now have Tom's body cease to function. So if you look at cause and effect, you're the respiratory therapist, you remove the ventilator, and in short order, Tom dies. Well, it seems like cause and effect again. You move the ventilator, you caused my death. You got to ask ethically, why is Tom on the ventilator in the first place? Because he may be compromised with Lou Gehrig's disease, for example. And so it's not the removal of the ventilator that causes Tom's death, it's the underlying condition, the Lou Gehrig's disease. You see the difference when you sort it out ethically and legally using that kind of perspective? But the key that the passive euthanasia could be morally reprehensible in this regard. You have to ask yourself as the respiratory therapist, why are you removing that respirator from Tom? If your intention is to make Tom be dead, then I would have some problem with that in terms of moral culpability. But if you're stopping that ventilator because it's burdensome treatment, which the bishops say we have every right to refuse morally, that's a whole different story. Your intention now is to enable Tom to avoid burdensome treatment. That it's actually a benefit to Tom to remove that medical intervention. That's, again, the ethical way of looking at that. So be careful about, because truth be known, if you have 10 deaths in a hospital today, 9 of them probably will involve removing some kind of medical intervention that's holding death at bay. So you'd have that hospital guilty of 9 cases of euthanasia if you push the passive so hard. To give you a humorous illustration, so I've made someone angry, and they're just looking at a way to do me in, but they don't want to go to jail for it, for homicide. So here I leave my Harry Hines Hospice office, late sun now, I'm walking west into the sun, and I'm so deep in prayer, people will question that one immediately, and I don't realize that the light is red. So I just keep on walking, and lo and behold, I'm walking south. The driver who's wanting to do me in has a green light, and he sees me in the middle of the intersection. Perfect opportunity. So he hits the throttle, and he nuts me in, but now to make it look good, he gets across the intersection, and he looks in the rearview mirror. I didn't realize how tough I am. I'm lifting my head. My legs are broken. And so if he wanted me dead, what's he going to do? He's going to put it in reverse and hit me again. But if it really is an accident, sun, the light was green, Tom was walking against the red light, what will he do? He'll stop and come back. Intention. So even in a court of law, if it's an accident, fine. But if he did kill me and it went to a court of law, would he be found guilty for homicide? Well, it would be involuntary manslaughter. I guess you have those categories. But he wouldn't be going to jail because no one knows that he intended to hit me and he could have avoided me. You see, I hope it's not too complex to sort that out. But that's why I want to make sure we understand very carefully, make those distinctions that I talked about with euthanasia. And you go back to your original question. To simply allow the underlying condition to run its course, allowing death to occur, is not hastening death. Hastening death has to do with something that's brought in from the outside rather than what's already going on in my body. I would, as an ethicist, go to the clinician and say, what's going on with Sandy in terms of her functioning? Is there an underlying condition that you're now circumventing with your intervention that's causing her some burdensome aspect? So I want to find out from the clinician first. So is it just a lot of suicides today, there's nothing going on, but there's something in terms of the physical, usually a lot of depression going on. So we don't justify morally any and all suicide, though we kind of are a little more lenient in saying they probably were not having total existential capacity, because depression can really do a number. So before I would work with you in terms of that particular question, I would probably focus in on the existential questions. That what I said earlier, those are sometimes can cause more suffering. So if we can give you the proper support, despite your handicaps, to deal with that, that would be the route that I would say we need to go. But I would not simply say, just simply because you want to die, yeah, let's go for it. No, that would be not what I would advise.